Now being recorded.
Good afternoon. My name is Greg Fieri with the Office of Behavioral and Social Sciences Research at NIH. I'm pleased to welcome you to today's and this month's NIH Adherence Network Distinguished Speaker Series. Today we have the honor of hearing from Dr. Dr. James Aikens. He's an associate professor in the Department of Family Medicine and a faculty affiliate of the Center for Managing Chronic Disease at the University of Michigan. And today he's going to be telling us about a new intervention for chronic disease management in his talk entitled mHealth-Enhanced Support from Informal Caregivers Improves Med Adherence Across 3 Chronic Conditions. Dr. Aikens?
Thank you, Greg. Thanks. I want to thank you as well as Dr. Wendy Nilsson for hosting this speaker series. And I'm delighted to be here at the Office for Behavioral and Social Sciences Research at the beautiful NIH campus. Just before getting started, I just want to introduce that we'll be covering really several years of work done at the University of Michigan, much of it in collaboration with Dr. John Pate at the School of Public Health and the Ann Arbor VA. And what we've done is essentially taken standard telemonitoring for chronic conditions and integrated informal caregivers in order to not only improve the patient's self-management support, but also hopefully relieving the burden of any in-home caregiver if the patient has one. And what I'll be doing is talking about this system that we've created and running through our results with 3 different conditions. These will be in the order I'll be doing them: diabetes, and then congestive heart failure, and finally depression. And rather than focusing on the minute differences between the different studies and the differences in protocols and slight differences in results, I'll really just be focusing on their commonalities so that we can pull it all together and draw some conclusions. So first of all, I just want to give an overview of what we'll be doing, talking first about the general issue of self-management and chronic illness and how care management and caregiving fit with that. We'll then be looking at just what is the system that we created to connect patients with their caregivers and their clinicians. And then I'll go through our results on and we'll be wrapping it up with conclusions and integrating it all together, hopefully. So to kind of come up level and take a look at just what is this problem we're dealing with. When you think about chronic occasionally to ever really take care of in terms of patient education and creating new habits, new behaviors, and reinforcing these over time. It's just not something that a live clinician can do within the constraints of clinical care. So along came care management, probably up to 3 decades ago, and really solved some of these problems at least part way, so that across many, many conditions, including those I'll be talking about today, care management does improve outcomes, and even in co-occurring conditions, as you see here in the studies by Dr. Caton and his colleagues at Seattle, where patients not only have depression but also either diabetes or cardiovascular disease, and this has been done in several other combinations as well. So the problem is that care management also has its limits in terms of it does require personnel, and they need to be trained adequately and available, and if they are also clinicians such as nurses or behavioral health providers, they can't be in clinic providing care at that time that they're providing care management. There's issues, of course, with healthcare financing with just about anything, and they apply here too in terms of adequate reimbursement and again that their clinical revenue might be displaced by care management activities, even with cost effectiveness or cost offset taken into account. There's technical issues with infrastructure to the point where we like to these days see many systems where care managers are assisted by some automated element, whether it's automated phone calls and the like. But this has its limitations, especially for under-resourced clinics, to the point where some clinics are outsourcing their care management to centralized agencies. And so the result of all this is that what was initially designed to be or intended to be a proactive system, which was supposed to be able to anticipate, detect, preempt these clinical problems before they occurred or as they were occurring, and provide just-in-time responses on the part of the clinic, has, in many cases, especially in under-resourced clinics, devolved into what's more of a reactive service, where they're really spending the bulk of their time dealing with patients who were recently discharged from the hospital, or patients who are newly diagnosed with the condition, or those who are in an acute, urgent situation, and in some cases dealing with those patients who are most assertive. So we got very interested in focusing on informal caregivers, and there's several reasons for this. Informal caregivers, meaning another person in the patient's life, one of the main reasons why they're so important in this scenario is that they are already invested in the patient's outcome, right? So they're already motivated and really don't necessarily need to enhance that. It's already in place, and they don't need to be maintained. There's a great deal of correlational research suggesting that having a caregiver involved improves outcomes, and primary care providers know this and are usually highly approving when a caregiver can be involved. So what are the limitations of caregiving? The main thing we usually hear about in the literature is that burnout is quite prevalent. This is because they're overburdened with taking care of someone at home, and often these are aging older adults who have chronic health problems of their own. So the solution that we have offered with this is the concept of distance caregiving through what we call a care partner, and I'll be using that term a lot today. You can also, if I have the abbreviation CP in some of the slides, that refers to the care partner. A care partner in this system is somebody from outside the home. They don't need to be long distance, but they could be. And this is typically a family member of the patient, most typically a son or daughter who's grown into an adult and has moved out, but it could also be a close friend. Even with a care partner involved, helping out an in-home caregiver if there is one, they're still going to not have the formal tools that they need in order to provide good self-management support. They don't necessarily know, especially the out-of-home caregivers, what to be monitoring and how to coordinate with any in-home caregiver. They don't necessarily keep graphs or keep track of what was happening last week or last month in order to detect trends and work with this kind of data. And they also require some structured guidance in order to know what to do when a problem does occur. So what we do with this is we're a big fan of simple, robust technologies that are easy to set up and difficult to break. So we also have incorporated mobile tools along with this. IVR monitoring, and IVR refers to interactive voice response. And IVR is essentially when the patient hears a pre-recorded query or message, a question, and they reply in this system, not with their voice and voice recognition of their answer, but by using their touch-tone keypad. And we do it specifically in this manner because many older patients early on, they nixed the idea of voice recognition. They weren't comfortable with the technology. Some people have accents that make it difficult to translate their voice, and it just kind of rattled some of the older patients. And so we stuck with touch-tone keypad responding, which has turned out to be quite popular and easy for people to do. So we use voice recording, pre-recorded human voices. So there's no theory involved in this intervention anywhere. And we also employ email texting and faxing with clinicians and a website. Now, the thing I want to point out from the beginning is that the patient in this system does not need to have any of this. All they really need to do is have a phone, and it doesn't need to be a mobile phone. It could be a landline, as long as it has a touch-tone keypad, and I think they all do now. The care partner needs to have email and access to the web. It's one and the same thing. But that could be once a week, say. They could even go to a public library and do that, and some do. And the clinician, most of them prefer to be getting their notifications either by web or by fax. So one of the features of this is that when a patient encounters a problem and reports it through their touch-tone keypad, they will get feedback in real time. They'll get an explanation of why what's happening is a problem and what they might do about it. And I'll give some samples of that feedback in a few minutes. The clinicians, it's very important in this system not to overwhelm clinicians with urgent problems reported by the patient. So we set the thresholds very carefully for when a clinician should get notified. And again, this is usually through fax, so that it's really going to enhance their workflow and not interfere with it. The other feature in this system, and we haven't done this in the data I'll be presenting, but it can be done and is being done currently, is that the thresholds for triggering the notification to the clinician, and these are just for urgent problems, they can be adjusted. They can be adjusted by the clinician. They can also be adjusted at the level of the patient. The patient doesn't adjust them, but they can be adjusted for specific patients. So the system is really quite flexible in that sense. And finally, the caregiver that's recruited into the system, the long-distance caregiver, gets advice or guidance on, if the patient's reporting a problem, what they might be able to do to support the patient, assist the patient, and so forth to hopefully move towards better self-management. So here's the system in pictures. We've got the call-in computer based back at the university, and this contains all the voice recordings and all the patient's phone numbers, and it's programmed to call them each week. If the patient doesn't answer, it'll keep calling them, and the patient, when they join and enroll in this project, they give us up to 9 days and times each week when they would prefer to be called. So it'll run through these in order, trying to reach the patient each week. And so this is really helpful and you'll see later in terms of our call completion rate. So the patient gets the call, gets asked questions, and answers them using the touch-tone pad once again. And based on what they report, they're going to get some feedback. And in the form of, if they're having a self-management problem or even a medical crisis, they'll get some advice about what to do. And this could be anything from, you might try this strategy to work with your activity or your diet or your medication, all the way up to, you should call 911, and we'll notify your clinician, but you should go ahead and call 911 or get to the emergency room. It all depends on the severity of what's being reported. For urgent problems only, the clinician will receive a fax alert, and I've already explained that. And finally, this care partner is going to get a notification, either email or text. Okay. Now, the care partner will get notifications at a much lower threshold than the clinician. The clinician's only hearing about what they want to hear about, set at a very high threshold. The care partner, we set the threshold much lower so that they can help with preventing problems before they become big problems. Here's the system in a schematic with the patient in the center. It's all tied together with the infrastructure and the call-in computer managing everything. We've got the clinician getting notified as needed, the care partner getting their notifications, and as you can see, the care partner is coordinating with any in-home caregiver that the patient might have. And anywhere from 40 to 70% of our patients have this in-home caregiver. In some studies, patients are required to have a care partner, and in other studies they're not. We'll be talking about those differences as they come up. And as you can see, the patient is connected with the care partner and the in-home caregiver. There's the triangle there. The clinician is only connected with the patient, and the care partner really is not functioning as any kind of intermediary between the patient and their clinician. That's something we want to avoid. We want to always be empowering the patient to contact their clinician when needed, unless it's an urgent emergency. Okay, here is a mind-boggling and probably eye-boggling schematic or outlay of what some of the call flow looks like. These boxes in black text are the pre-recorded text. The red sections indicate the patient's responses, and as you can see, there's all sorts of tree branching algorithms based on what the patient replies. And let's zoom in on this, on just one section of it, so you can see that here in the center, sort of, the patient's getting asked about their overall health, and they could answer with a star to repeat it, 1, 2, or 3, or they could give a non-answer and it would get repeated. And as you can see, it takes them to different places, and different follow-up questions proceed from that. Just so you can get a sense for what we're asking the patient, particularly for today's presentation, I want to let you know what the medication adherence item is going to look like. These are what they're getting asked, again, in their weekly calls. And as you can see, there's 4 responses for different degrees of adherence. If the adherence was reported as a sometimes or rarely or never, then we'd be notifying the care partner. We'd only really notify the clinician about this if it was clinically concerning and if it was occurring along with some concerning symptoms. And again, this varies somewhat by condition. However, when I talk about non-adherence in today's, the data we'll be seeing today, we define it much more strictly as anything less than perfect adherence is non-adherence. And we do this on purpose to kind of counteract the tendency for social desirability bias in adherence self-reports, and it really works out to be coming out about the right rates and appears to be valid data. So that's how we prefer to process that information, at least for the purposes of data analysis. Most of the questions patients are getting asked are not this complex. Most of the time, they're really just giving a dichotomous response like this. Yes, no, 1 or 2. Okay, and so what do they get back? If they typed in a 3 or 4 on that, they might get something like this, and there's many variations on this. But as you can see, this is going to involve some adherence strategies, in this case for forgetting, and creating a habit that's tailored around the daily routine, in this case, say, putting it near your coffee pot or toothbrush. What does the care partner get? And this would include several elements. It's going to state what the problem was and why it is medically significant. But most importantly, what are some of the things they can do to help? And it doesn't necessarily ask them to solve the problem in most cases. In this case, just a reminder that, hey, medication for depression usually doesn't work until it's been taken for several weeks. You might want to remind them of that. You should keep taking it even if you're not feeling better yet. Should not skip it. And if you're having side effects, you should contact your prescriber. Okay. So before we launched into this, and even as we were collecting pilot data, we became aware of several potential barriers. These are actually baboons on the road in South Africa that do present barriers as well to the traveler. And so our barriers were things that, some of them that we thought of and preempted, and some of them were suggested to us by others. there was, first of all, who wants to answer a robocall on an every week basis? And first of all, these aren't robocalls, but there was this idea that patients just aren't going to want to participate in such a thing. And even if they do, that their participation will drop greatly over time. There's this thought that older patients would be technophobic, wouldn't want to use this kind of technology or deal with an automated phone call. Same thing for minorities and vulnerable SES groups, that they wouldn't engage. There was also this thought that you're introducing a new person into what might have been a pre-existing caregiving dyad, an in-home caregiver and the patient. And what happens if they conflict? What if this new caregiver steps on the toes of the existing caregiver, where they're not getting along, or they work at cross purposes? So this was a concern from the very beginning. And finally, that what happens if a patient has nobody to nominate for their care partner? Some patients really have no living family or any close friends that they would be comfortable engaging in this way. So let me take each one of these at once and talk about how this played out. First of all, patients won't participate. What we find is that they do complete 83% of their calls on average, which is really quite good. These are, what this number is at a nuts and bolts level, this means 83% of the weeks when a call was attempted, it was completed. And remember, there could be up to 9 attempts. Sometimes the system was turned off, say if a patient was traveling or hospitalized, and so a call wasn't attempted every single week that a patient was in the study. You see up at the top here, and I don't have a circle around it, but this is data from the 1,300 subjects who had one of these 4 conditions. I won't be discussing the cancer data today, but you see that these call weeks in the second row, what a call week is simply a unit of analysis patient in the study for 1 week. So this is close to 30,000 call weeks on these 1,300 patients. It's about 6 months on average per patient. Okay, there's one more thing I'm going to try to show on this slide. I guess it's not going to work, but let me just verbally take you through it. There it goes. These completion rates aren't perfectly uniform by condition, and not surprisingly, they're lowest in depression, but they're still 71%, and they're up to 90% in heart failure. About how participation plays out over time, and remember our studies lasted from anywhere from some of them 3 months and some of them 12 months. So, but what you'll see here is on these different conditions, the probability of call completion broken down by week of the study. And here you see in heart failure, it holds quite steady for a whole year. In diabetes, there's just a very slight degradation, but it's fairly systematic, but really very slight. Still a great deal of the calls are completed by the end of the study. And in depression, it starts off at about 80%, and it goes down over these weeks, down to probably a little bit below 75%. Still quite good. Okay, so that older patients won't use this system. The fact is that when you plot age against probability of completion, they actually do better than the younger folks. And this could just be that they're retired and they're at home more often, but that's definitely not a concern. Okay, there's the idea that the vulnerable groups won't participate, and what you see here is highlighted on certainly older patients are represented in great numbers in our studies. As in terms of when you cut income at $30,000 or cut high school and below education, we have healthy numbers of those subjects in these participants in these studies. And you'll also see that there's at least a healthy degree of non-white participants, anywhere from over 20% to up to 35%. So the idea that patients won't have an eligible care partner. Well, let's look at what a care partner is supposed to be. What are our criteria? They need to be an adult, and they need to be living outside the household. And again, the idea for that is we want to shift burden away from the in-home caregiver. They need to be somebody the patient routinely has talked with before participating, so that communicating routinely isn't a new concept. They need to have a phone, and they also need to have internet connectivity. And although patients, as I said, don't need even to know how to use a computer, and they don't need a smartphone, none of that, the care partner needs to be connected to be able to get an email once a week. We find, this really isn't a problem because most of these care partners are the grown son or daughter of a patient, and so they're in this age bracket, 30s to 40s, 20s, 30s, 40s, where they're quite connected. It's really pretty much the norm. As for there not being any caregiver available, we have 77% of patients are having one. Now this number is slightly inflated because you see in heart failure and cancer they were required. That's why they're at 100%. So when we just look at the studies where they weren't required, depression and diabetes, you still see that on average about 2/3 of patients do have a candidate. Okay, and having a care partner, as you can see in the very last row, predicts call completion. It's based on that adjusted odds ratio, which is adjusted for education and income and so forth. This means that there's 36% greater probability of call completion if you have a care partner. Idea of inter-caregiver conflict. What we do to prevent this is we screen very carefully for a supportive caregiver, and this has to be a person who the patient rates on standardized scales as highly supportive, and that they've never really had a conflict, that they're compatible with any in-home caregiver. We monitor throughout the project for conflict between the caregivers, so in case anything develops, we would hopefully know about it. And we also monitor to make sure that the supportive caregiver, the care partner, doesn't burn out. So far out of 26,000 plus patient weeks, we've had no incidents where we detected any conflict. Okay, I'll now launch into disease by disease, starting with diabetes. And much of this data is published. Here I'll be presenting data on 300 subjects, 300 patients from these participants all came from VAs, from a variety of VA clinics throughout the Midwest, and very high recruitment rate. 72% of those approached agreed to participate. Now they had the option of participating with a care partner. So even if they had a care partner, they didn't have to engage them in the study. So about 40% of these, almost all men, decided to do that. And this study lasted from 3 to 6 months of the telemonitoring system. The reason it's 6 months sometimes is that about 1/3 of the way through the study we extended the timeline because things were going well enough to justify that. And so about 2/3 of the participants were in the longer protocol. So these were average age of 67. They had comorbid conditions. They had physical impairment from these conditions, and this is the physical component summary from the short form 36 from medical outcome study. And they had medication non-adherence. So this is the elevated score on the Mariski medication adherence scale, and 36% of them were categorized by this measure as non-adherent at baseline. So 5,700 patient weeks of participation. The call completion was 84%, quite good in this study. Call completion deteriorated ever so slightly over time, but this was reliable enough to be significant, just 4% per week of participation. If you were not married, you were less likely to complete your call. Also, those who were distressed about their condition at baseline and those who were, and this is no surprise, those who were less adherent to medication at baseline were less adherent with the study protocol. The notifications, these urgent notifications to the clinics, went out for about 1 out of every 5 calls. These actually were clustered such that about half of patients, about a tenth of patients generated half of the notifications. So highly clustered within a few individuals. These folks that generated the notifications tended to be older and more impaired. But let's look at the reasons why the notifications went out. They tended to be high blood pressure or low blood glucose. So 2 things that we'd be very concerned about. Now what you see here is broken down by week. We see the probability of different problems occurring, being reported on the weekly call. And the dotted lines, this is a little complex, so let me explain it. The dotted lines are actually referenced to the right axis because those prevalences were so low, they would have been very, very low-lying, small-looking lines compared to the others because the scale's different. They were just much more rare. So for the solid lines, you look at the left axis, and for the dotted lines, you look at the right axis. So medication adherence, as you can see, it looks like it increased over time, and it did systematically by week, with the bulk of this change, if not all of it, occurring in the first 6 weeks of the study. Self-monitoring of blood glucose, that went up each week. It was high to begin with, and it ended up very high. Same thing with with checking feet. This is checking feet for injuries or sores. High blood glucose became less likely over time, as did low blood glucose. Okay, and now it's expressed as odds ratios. So what you see here are, this is the impact of each week would have on the probability of these problems, so that each week that went by was associated with a 2 to 7% decrease in the odds of these problems being reported. Here are the chances of good adherence being reported week by week, and it's broken down now by whether they participated with this care partner. So this was a significant effect by care partner, and what we see is odds ratio of 1.8, and if you can visually just look at these graphs, you'll see that most of the difference seems to be that those without a care partner pretty much leveled out after 3 months in this 6-month protocol. If you had a care partner, you kept on increasing in adherence throughout the protocol. And if I break this down into the first 3 months versus the second 3 months, you can really see these percentages as they play out. Okay, here in this white box that just appeared on the right, these are with and without a care partner. It's about 77% whether you're in the first or the second half of the study. But if you have a care partner, it's 91% on average in the second half of the study. So that's where that difference is being driven from, second half. Okay, so based on this, we now have an ongoing randomized control trial funded by NIDDK. Here's a quick schematic of that study protocol. We're recruiting 284 patients. We're going to 4 community clinics. This is not being conducted in the VA. So we're actually very interested in working with federally qualified health centers, or FQHCs, because we want this intervention to work and be most applicable to those who are the least insured and the medically underserved. So, and we're in the process of rolling out to 2 more clinics now. They get randomized to mHealth-supported care partner and assessed at 6 and 12 months, in this case on glycosylated hemoglobin or HbA1c for their glycemic control and diabetes related to stress. We're also measuring their blood pressures at baseline 6 and 12 months. So we're now in year 3, actually beginning 4 of 5, and we've recruited over half of our patients. So each patient has a care partner, and well over half of them have an in-home caregiver, and again, that's just by chance. So we've got 100 of these patients are halfway through the study, and just 24 have completed, but dropout is, if you can base it on 24 people, it's really just about, there would have been 26 had none dropped out, so only about a 10% dropout. All right, I'll move on now into congestive heart failure, CHF. This study, we'll go through these much more quickly because now that I think you can understand the basic methodology, we're just working with different content in different illnesses. 372 VA patients. Okay, and they were in the mHealth program for a full year. They got their IVR calls, assessed their symptoms, especially shortness of breath and swelling in the extremities. Medication adherence, as we saw before. They also were assessed on whether they've been weighing themselves and moderating their salt and fluid intakes as they were recommended to, and whether they had experienced significant weight gain. They also received self-management support, as we've explained before, or as I've explained before, in the form of the patient feedback that's immediately given when they report a problem. The notifications went to their clinician, and as a patient care partner unit, they were randomized to whether the care partner got feedback from this system or not. Okay, lots of person weeks because it was a 1-year study with that many people. Our attrition was quite low, and we couldn't really predict attrition with any of our baseline variables. Lots of calls completed. In this case, different from diabetes, there were fewer notifications, more like 10 notifications per 100 patient weeks. So if a clinic had, say, 10 patients in this study participating, they might get 1 notification. Let's take a look at what predicted call completion and what predicted urgent alerts. Incomplete calls were more likely to happen in those with socioeconomic disadvantage or minorities, or those who were missing outpatient clinic appointments to begin with. It was also more likely in those with severe disease, and not surprisingly, they were the same people who went to the emergency department more often. The urgent faxes were related to some of the same things, distress about illness as well, some of the psychological factors, but primarily severe disease, lots of comorbidities, and using the emergency room often, frequently at baseline. Here's the same play out of behaviors over time. This, again, is not breaking down yet by whether there's a care partner. But taking medication did not change week by week during the study. There was an increase in the probability of weighing oneself, decrease in consuming excess fluids, and consuming excess sodium. Okay. Now we break it down by whether there was the care partner was integrated into the system. In other words, whether the care partner got notifications as well. You can look at this with the eyeball test and tell that there's a difference here, that really it started off at the beginning and stayed quite consistent, with possibly even a slight decrease over time in those whose care partners weren't connected with the system, and a slight increase in those whose care partners were, odds ratio of 1.6. Then when you look at medication adherence at baseline versus month 12, no difference in the care partners not connected with the system, and significant effect in the favor of improved adherence when the care partner was connected. And now we also have these other outcomes. We'll look at, this is the effect on weight gain. It might not look like a lot visually, but you see especially in the last, say, 4 months of the trial, there's something, looks like something's going on, and this is a reduction in probability of 25%. Okay, based on this, we have two related ongoing trials happening. This one's supported by ARC, and this one's supported by National Institute of Aging, and they'll be rolling for a few more years. None of those results are in yet. I'll move right into primary care depression at this point. This data comes from a trial with, will my slide advance? Uh-oh. Okay, back on track. There were over 200 patients in this trial. They, like the diabetes patients, had the option of participating with a care partner or without. And the vast majority had a care partner participating with them. This study had a 6-month duration. The calls assessed depressive symptoms as well as antidepressant adherence. We asked about, basically these were the Patient Health Questionnaire 9, or the widely used PHQ 9, which includes the item about suicidality, and we had several follow-up prompts if that was positive. And if there was any suicidality that we could interpret as risky, the patient was not only offered an immediate connection to a suicide helpline, the clinician was notified, the care partner was notified if there was one, and in some cases a senior clinician from the research side would also follow up with the patient for safety reasons. So they received self-management support, especially around issues of minor changes in depression, minor increases, as well as problems with adherence. Clinical notifications went out to the clinicians, just like in the other study, and feedback to the care partner. If anybody's wondering whether a depressed patient would want to even interact with IVR, there's quite a good deal of background data suggesting that this isn't really a problem. Many trials have collected their data this way, including data on suicidality. So it may be surprising, but it works quite well. Here we see the baseline depression severity had really nothing to do with the probability of participating in the calls. So let's look at medication adherence. These are smoothed data rather than raw data because, as you can expect, the week-to-week data are kind of irregular and look a lot like a stock market, so we try to make them more interpretable. This is not the data we analyze. This just gives a better graphical representation. So you see that in the second half of the trial, it seemed to, that's where the differences on medication adherence seem to play out. All right. This is adjusted this is even after taking account of some demographic factors, the week that they're in the study, and how severe their depression was at baseline. Depressive symptoms, and what you see graphed here is the probability of being in the depressed range, or the opposite of remission. So the care partner side on the right, they had a lower probability of having a depressed score. So their PHQs moved into remission, in other words, and that was an odds ratio. They were only about half as likely to have this elevated PHQ. And here, again, smooth data with a quadratic transformation. These are the reports of suicidal ideation, and we see quite a marked and beneficial effect there. Okay, and that was statistically significant. These suicidal ideation, these are really low prevalence reports, and so it can be difficult to interpret without transforming the data to some extent. But I should say that the data that we analyzed were raw data, not transformed. All right, so we've got this trial going on funded by NIMH, and this is going to recruit a little over 200 patients and their care partners. Probably half will have an in-home caregiver. And again, we're working with federally qualified health centers. They need to have at least a moderate level of depressive symptoms to get into this study, and they're randomized to mHealth-supported care partner or not, and they're getting assessments, again, at 0, 6, and 12 months. So we're only in year 2 of 5 with this. We have 6 community clinics, and we have 75 of our 202 patient participants already recruited. So I will now wrap up with some conclusions and drawing some generalities across conditions. First of all, most patients can and will enroll with an informal caregiver. So it's at least 2/3. And when you gloss over the differences between disorders, this really has little to do with patient characteristics, sociodemographics. Having a care partner makes the participant more likely to complete their calls and more engaged in the study. These are the call completion rates, once again, by way of review. High rates in heart failure and diabetes, and a lower rate in depression, which decreases somewhat over time. But these axes are going from, I think, 60% to 100%, or 0.6 to 0.1 to 1.0, and so they're somewhat exaggerated looking. The responsiveness and engagement with the program has a lot more to do with program characteristics than patient characteristics when it really gets down to it. It's the frequency of calls, the length of the calls, and the complexity. And based on some of this, we've looked into making many changes in terms of making calls more flexible and adjusting the frequency of not only the calls themselves, but even specific items based on if stability has been achieved, say in depressive symptoms, then you really don't need to assess that every week. And this is probably a benefit for patients in terms of assessment burden. It also depends on the problem being targeted, of course. All right, and the amount of feedback that a participant's receiving. So if you answer a lot of questions positive, you will get more feedback. I didn't mention this before, but these calls tend to be 5 minutes long, and with a lot of feedback, they might be 10 minutes long, so average of about 6 or 7 minutes. So a second lesson is that having a caregiver involved does seem to increase week-to-week adherence. We saw this in diabetes, especially in months 4 through 6. We saw it in heart failure, and we observed it in depression as well, again in the second half. By the end of the study, by the end of a year in heart failure, there's a noteworthy increase in adherence to heart failure medication. So it's not only that, but other behaviors are also improving in terms of self-management. I don't have this data to show in a graph, but high glucose improved when a care partner was involved. Weight gain went down with care partner. We've got a little lag. Okay. Suicidality also benefits with the care partner, and having depression enter remission, it was much more likely to enter remission when a care partner was involved. Limitations. All right, we're really not engaging the highest risk patients as well as the lower risk patients. So people who are often hospitalized, who don't attend clinic appointments, and have psychological distress or mental health problems at baseline. Those are the patients who are the most difficult for us to hook in. The good news on that is that we really don't know what the optimal dose is, and it turns out that even very low call completion rates lead to benefit. So with ongoing studies in low-income nations where less than 60% of calls are completed, we really see there's still great benefit even with lesser engagement. So while the most needy patients might not engage as much, it seems like less goes further with them. We're not able to generalize to other medical groups just yet. And this isn't appropriate for patients with cognitive impairment. Incidentally, if there is any other system like this, they're all targeting patients with dementia, and they're completely oriented towards the in-home caregiver, not the patient. So of the only other systems we know of that involve a caregiver, they all involve dementia. So far as we know, this is the only service of its type that really engages both patients and caregivers and is patient-oriented. So we've had a lot of barriers recruiting clinics, and I think this is a nationwide problem that trialists have encountered. Clinical practices, primary care practices are actively reorganizing. They're dealing with adopting electronic health records, the Affordable Care Act, becoming a patient-centered medical home, accountable care organization. They're very concerned about the omnibus rule and what it has to do with protected health information. And once we agree with a clinic, there's a great deal of paperwork and legal issues to work out before clinic participation can actually proceed. And in some cases, we need to certify some of the clinicians on human subjects training to HHS standards. Okay, so where are we taking this next? And this is my just about final slide. I think my final slide. Okay. All right. We are obviously doing several ongoing trials. I'll have to ad-lib this one. We are looking closely at how patients perceive their care partner. We're looking at the effects on other household members. We're, as I said, looking into other interactive technologies, including handhelds of all types and more interactive text messaging. We're implementing in low-income countries and especially interested in how the algorithms can become smarter and not just more sophisticated, but can adapt to patients' responses over time and actually learn. And we're looking at not just using the system to assist informal caregivers, but also community health workers. Okay, and at that, it's time for me to start taking questions. If there are any, what do we have? I'll just pause for a minute while I look and see what questions have come in. Okay, so the first question comes from Marcos Reyes Estrada, asks, is it possible to integrate this intervention with other highly stigmatized diseases, such as HIV positive or STDs, where disclosing is an issue? I would say it's a sensitive topic, as sensitive, if not more, than depression, and we would expect some of the same, I think, social issues with the research in terms of IRBs give it much more scrutiny, and the information needs to be It needs to be proven and well established that the information is secure. We have really no problems with information security because the system is actually not connected to the internet, so that well, I should say it's not connected to telephone, so it can't be hacked by phone, and it's not connected to the internet. That's through another system where the data get downloaded to. So, so I'd say that as long as great care was taken in the selection of the care partner and screening, and with the sensitivity of the content and the items provided on IVR, that it should work just fine. It's somewhat more challenging, though, but it would certainly be quite important. I think especially in HIV, I'm also thinking tuberculosis, TB, with the lengthy regimen medications, where medication adherence of at least perfect or near perfect adherence is extraordinarily important. So with the effects we're seeing on adherence, I would think it's a great place to do this kind of work, just that you have some of the same issues we had with working with depressed patients in terms of sensitivity. Okay, I'll move on to the second question, which comes from Sandra Spolstra. I hope I'm pronouncing that correctly. Asks, do you believe a care partner will be just as effective in the use of text message adherence reminders? Do you know of anyone working on this approach? So we have experimented with text messaging. It seems to be a lot of content right now with the content that I showed for the care partner, quite a bit of content for a telephone screen, but there's no reason why it shouldn't work, and we expect to have decent results with that, just the same as we've been seeing. In fact, it may even be somewhat improved in the sense of we're checking our text messages much more often than our email. So in the sense, it's sort of like souped up email and perhaps less information. There's also much more opportunity for interactivity as well as an app in that scenario. Okay, let's see. Sandra Spolstra also asks, what do you believe is the influencing factor or factors in the last half of the studies that creates the difference in adherence? Or why did it work so-so in the beginning and well at the end of your studies? So what are my thoughts about this? I believe that almost anything you do has at least a temporary effect on adherence, especially when we're looking at self-reports. So you know, we could call this a Hawthorne effect, or the therapeutic reactivity of doing self-monitoring, especially when others are aware of the results. I also then would say that it wasn't in every condition that happened, but it was 2 out of 3. And that I think just to get that sustained effect, and we would presume this would probably not continue to improve, but at least be maintained over time. But to get the sustained effect, what we're seeing is maintenance when of these initial improvements when a care partner is involved. I should say we don't really see decline of the initial improvement, but it seems like when you're just getting when you're just getting telemonitoring, your improvement only improves, your adherence only improves so much, and then it seems to stall without a care partner. Okay, somebody asks if what were the IVR endpoints self-reported by the patients? Yes, that's correct. These are completely self-reported. We believe that the patients are doing the self-reporting because they're asked to verify that it's them, and to through a code at the beginning of the phone call. And if it was self-reported, what's the potential for systematic bias? Well, with any adherence reports, there's huge potential for bias. This is why we believe it was a good idea to categorize adherence as perfect versus less than perfect. There's still potential for bias just in terms of you're reporting it, you're going to get nagged by the telephone call, you're going to hear extra messages, it's going to take you more time if you report non-adherence. But I will say that yes, that's true. but we see this long-term effect with a totally different instrument at the end of the heart failure study, which was randomized. So that's the strongest study of these three. We also would think that if self-report bias was happening, on top of that, we still see this benefit with the care partner. And I'd be hard-pressed to think that self-report bias would be different when the care partner was present. I mean, it's possible, but we really think that that's through self-management support when we really drill down into our data. Okay, how do you deal with information that needs timely action, such as suicidal ideation? What we do is we assess any ideation quite thoroughly. We ask multi-item questions about its frequency, whether there's a plan for self-harm, whether the person has a discrete plan in mind, and whether they view themselves as likely to act on their plan, or even if they don't have a plan, are they likely to harm themselves, both in the next few days and the next few weeks. Because remember, a call doesn't happen for another week. So we want to know whether there's risk before the next call or after the next call. And we gauge our responses based on that. The more urgent requests would trigger a clinician associated with the research project to immediately or at least very promptly contact the patient and triage. The patient's immediately getting told you should, if this is high risk, that you should call 911 if you're in danger of harming yourself, and they are offered a connection to a suicide hotline. Also, even at very low rates of suicidality, we're alerting the clinicians. But we're asking patients to not count on that, because the clinician could be getting a fax on Saturday morning and not see it until Monday morning. So a number of things that happen there, and with the, let's see, 400 patients we've had so far, we haven't had any adverse events related to harm beyond hospitalization. I think suicidality resulting in hospitalization is an adverse event, but beyond that, we haven't had anything more serious. Okay, let's see, Wendy Nilsson, hello Wendy, from Office of Behavioral and Social Sciences Research, who organized this series, asks, what do you think would happen if you did this using phones or tablets? Would it be embraced by your population? So we believe that the use of, we've considered tablets. We're using phones for all of our intervention at this point. You might mean, what if the care partners only interacted through telephone? And I think that's the next area for future development would be interactive SMS and perhaps an app on the care partner's phone. As far as tablets, you know, another portable technology, I doubt that there will be as popular or as embraced as telephones are, and probably always will. You know, there's also, you could use your imagination and think about, wow, there's also things like wearable computers and Google Glass, and so we're imagining things that build off of those technologies eventually, but that's way off. Okay, we are out of time, if not over time, and I am going to say thank you for your attention, and again, thanks to Drs. Nilsson and Fury for organizing, and thanks to Nana Afari for her technical assistance, and thank you for your attention and your questions.